Wilson's disease is also called hepatolenticular degeneration. There is an abnormal biliary excretion of copper from the liver, and there is an inability to incorporate the copper into the ceruloplasmin. Therefore, the ceruloplasmin levels in the blood are low because what we measure is the bound component of ceruloplasmin, the copper that is bound to the ceruloplasmin. So indirectly, we're measuring the bound copper in the blood. So effectively, there is a defective copper transport in Wilson's disease. There's a genetic mutation which is linked to ATP7B gene, which can actually be tested. It's autosomal recessive in inheritance. The clinical features could be asymptomatic. They could have neurological manifestations like chorea, ataxia, dystonia, dysphonia, rigidity, tremors. In almost all neurologically involved Wilson's, we will find a KF ring, which is a brown pigment of copper which is deposited in the Descemet's membrane of the cornea, and it's seen in the upper and lower limbus. The slit lamp examination, you'd be able to see a golden brown color or a fluorescent green. You can also see, in some cases, sunflower cataracts, which are caused due to copper in the lens. Psychiatric manifestations include psychosis, depression, and poor sleep. Hepatic involvement, there could be acute liver failure, chronic hepatitis, and cirrhosis. Acute liver failure could be because of hepatocellular involvement, or it could be because of an excess amount of free copper causing hemolysis, increased unconjugated bilirubin, liver failure, and death. The treatment is liver transplant. Chronic hepatitis and cirrhosis, the typical feature would be an alkaline phosphatase would be paradoxically depressed. So the ALP to bilirubin ratio is less than 4. The AST is higher than the ALT, just like we see in alcoholic hepatitis and in cirrhosis. And the ratio is usually more than 2.2. Renal involvement involves aminoaciduria, nephrocalcinosis, type 2 renal tubular acidosis. Bone involvement, there could be arthralgias, osteomalacia, and chondrocalcinosis. Cardiac involvement involves arrhythmias and cardiomyopathy. Endocrine involvement includes infertility, amenorrhea, hypogonadism. The diagnostic test, the biochemistry test, would be alkaline phosphatase to total bilirubin of less than 4, AST to ALT more than 2.2. The ceruloplasmin drops to less than 20 milligrams percent, but the normal range is 30 to 50. Urine-free copper is elevated to more than 100 micrograms per day. And the normal excretion is less than 50 micrograms per day. Some places says 40 micrograms per day. And this, what we measure, is an unbound copper. Copper in liver biopsy by dry weight. You take 1 to 1.5 centimeters in a true cut biopsy needle, and it should be in a copper-free container that you transport it, and you should freeze the sample before transport. That's why it's called a freeze-dried sample. The normal would be less than 50 micrograms per gram of dry weight. More than 250 micrograms per gram is diagnostic. But copper in the liver can be elevated in other diseases like cholestatic diseases like PBC, PSC, biliary atresia, and Indian childhood cirrhosis. It can also be elevated in PFIC, Alagille syndrome. The treatment, chelation, and reduce further copper absorption from the gut. The chelation methods we use are penicillamine and trientine. Trientine is used if the patient is intolerant or develops some side effects with the penicillamine. The first thing we have to do is penicillamine. We start at 250 milligrams once or twice a day, and we slowly titrate it upwards to 500 milligrams twice a day or 250 6 hourly. We monitor for lupus-like reactions, bone marrow toxicity. We have to give supplemental B6, just like in INH. We reduce the dose in pregnancy and before a surgery, because there is evidence of decreased wound healing with it. You monitor the efficacy by the serum-free copper. It should be less than 10 micrograms percent. And the 24-hour urine copper should be high because the penicillamine binds it and excretes it. So it's more than 250 micrograms in 24 hours. The side effect of penicillamine is a typical progeric change can happen. The patient can get wrinkled and look quite old. There are skin changes like elastosis perforans serpeginosa which can happen. Trientine, the dose is the same as penicillamine. You monitor for sideroblastic anemia. You monitor the efficacy just like in penicillamine. Zinc is given at 50 milligrams 3 times a day. You monitor by the urine copper excretion should be low, less than, because it's not a copper binder, unlike penicillamine and trientine. Urine copper should be less than 150 micrograms in 24 hours. Urine zinc should be high. That's more than 1,000 micrograms in 24 hours. And the serum-free copper should be less than 10 micrograms